Good afternoon on the East Coast. This is Lisa Dulski-Watkins with the Millbank Memorial Fund Multi-State Collaborative. You are logged into or calling into our monthly topical webinar. I'd like to welcome you all and thank you for dialing in at the end of the summer and what is a holiday week for many people. I am delighted today to introduce my friends and colleagues, Stefani Hartsfield and Nancy Eldridge. They're going to be giving us a really exciting talk about the work that they have been doing for quite a few years now in pursuit of improvement around integrated housing-based care management model. And we've had that writ large here in the state of Vermont through the Support and Services at Home program, the SASH. As a quick reminder, just if you're not going to be speaking or asking questions on the call, please put yourself on mute, either through your audio or your computer audio or through your phone. We can minimize noise on the ambient side that way, and it's very helpful. There is a chat function that all of you have access to if you'd like to ask questions and sort of have them in a parking lot while Nancy and Stefani are doing their presentation. Please do that, and we'll make sure that your questions get answered and the discussion can go on. I want to thank everybody for dialing in. This is a very exciting talk, and I'm going to turn it over to our presenters in just a moment, but I would like to first introduce them. Nancy Rockett Eldridge is the CEO of the National Well Home Network. She is a nationally recognized expert with 37 years of leadership experience in housing and health policy. She is the CEO and founder of the National Well Home Network, and her goal is to create an integrated system of supports that empower seniors to age well in the place and how that they choose to do so. She formerly served as the CEO of the Cathedral Square Corporation, where she actually was the creator of the Support and Services at Home, the SASH model, which is now serving 140 affordable housing communities in Vermont. She has been doing a great deal of work over the years at the University of Vermont College of Medicine and through the Vermont Medical Society, leading complex policy change and working in partnership with the academic and medical communities, as well as Medicaid, Medicare, et cetera. She serves as a board member of the Blue Cross Blue Shield of Vermont and is an alumnus of the Kennedy School of Government's Achieving Excellence program at Harvard and has a master's in urban and environmental policy from Tufts. Also like to introduce Stefani Hartsfield, who currently owns her own consulting company, Hartsfield Health Systems Consulting, focuses on the impact of integrated team-based care delivery systems. Previous to that, Stefani served as the Community Health Improvement Manager at the University of Vermont Medical Center. Her role encompassed management of performance improvement and change management initiatives in the Community Health Improvement Division. She has over 20 years of background in training and organizational development in various sectors of the social service industry. And she and Nancy worked together from 2009 to 2018 on the Support and Services at Home program. She consistently embodies a strategic focus on training, integrated team-based care, health information technology development, and quality improvement through all of her work. So with that, I'd like to hand things over to my friends and colleagues, Nancy and Stefani.
Thank you, Lisa. This is Nancy, and I'll start, and then I'll hand it off to Stefani. We'll go back and forth a little bit and share in the presentation. It is a real pleasure for us to speak with all of you involved in the CPC Plus medical home model, because SASH is actually, it was designed to serve as an extender to medical homes here in Vermont, and has proven to achieve the CPC Plus goals of improved quality of care, improved access to care, and reducing unnecessary services and reducing both Medicare and Medicaid spending. I wanted to start out by saying that SASH is a population health model, yet also has the flexibility and nimbleness to focus on your highest need patients. And I also wanted to emphasize that it is not a housing model. It is located where your highest need patients live, but it is not a housing model like you'll hear about supportive housing models that serve the homeless or individuals with mental health needs in a concentrated residential setting. So our goal is really to make sure seniors and younger people with disabilities can remain right where they're living, whether it's in subsidized low-income housing or in the community surrounding those properties. And our goal is most definitely to impact social determinants of health, in particular the behaviors of your patients and the behaviors that result in chronic conditions. Recently, a Forbes article written by Howard Gleckman, he's a senior fellow at the Urban Institute, asked the question, what if housing sites worked with on-site nurses and social workers to help frail older adults and younger people stay in their apartments? And the answer was, yes, they definitely can. A study that was released from HHS, the ASPE office, recently concluded that SASH was delivering care management and wellness nursing services to low-income seniors, that it was a win-win for residents. And in that evaluation, which was actually conducted by RTI and Leading Age, they concluded that we were not only reducing the rate of growth in Medicare spending, but also reducing the rate of growth in Medicaid spending. So really positive results there. So Lisa and Stefani and I have worked together for many years. 20 years ago this month, I left the UVM College of Medicine. I had been their director of primary care, had a huge respect for physicians, for hospitals, for the payer community, and left the College of Medicine to lead a nonprofit housing organization called Cathedral Square Corporation. And then when I accepted the job, I said, my key goal here in leaving the medical world to move to the housing world is to integrate health and housing. So after piloting the SASH model in 2009 to 2010, we were very, very fortunate that Lisa and Dr. Craig Jones had been working to manage chronic conditions in Vermont through the Blueprint for Health, and they were applying for the multi-payer advanced primary care practices demonstration through CMS. And Vermont was lucky to be one of the 8 states selected for that demonstration. And this is really what set us up to be the extender of medical homes. So the way the Blueprint for Health presented the concept to CMS was that medical homes, either individually or as a group, would representing 20,000 patients, would benefit from the creation of a community health teams that would support those 20,000 patients, with community health team members being social workers and nutritionists and other supports that most primary care practices wouldn't have on staff. And then, as you can see, SASH was to support both community health teams and medical homes. The difference there was that the panel size for the SASH participants was 100 participants versus the 20,000. So we were supporting the highest need, lowest income population. So why was it important to base these extenders in housing? And when I say housing, I mean housing that is subsidized by HUD. It's often financed by low-income housing tax credits through the IRS. In Vermont, it's many USDA rural development housing communities. So we literally have hundreds of these sites in Vermont. And now, as Lisa said, we have SASH at 140 separate properties in every corner of the state. So the number one reason I wanted to base SASH in housing was that the research shows that the number of chronically ill and the number of chronic conditions that individuals have living in HUD-assisted housing is much higher than that of individuals who are living in the larger community. And of course, these properties, because some of them are very large, I think our largest in Vermont is 165 units, but in the communities you all serve, they're probably much larger. So they create this opportunity to create a hub. And within that hub, you have this high concentration of high need residents who are your patients. Second reason we wanted to base it in housing is that we know that behavior drives health, and we know behaviors are shaped at home. They're not shaped at the doctor's office. It's day to day to day that behaviors are shaped. And so what we found in SASH is that primary care physicians have been really, really happy that we're able to, for example, address the diagnosed hypertensive patient population in physician practices and control blood pressures through daily monitoring and daily support that we can do from the patient's home. We've also been able to address other issues like hoarding, where if we can address hoarding, you avoid homelessness and that whole spiraling down of complex issues. We also saw, to my surprise, that there was actually limited access to care for our residents, even in our most urban communities in Vermont. Many of our residents did not have a primary care physician. In rural areas, many did not have not only not access to physicians, but access to the services that they were eligible for. And of course, many of our residents just find it difficult to get to the doctor's office, even if it's very close by. Somebody in a wheelchair, somebody with incontinence. It is very difficult to get to a nearby clinic or primary care practice. And so that's why we've embedded telemedicine into SASH. The next reason that we wanted to embed SASH in housing is that the alternatives to that were very costly. And I was seeing, in the early 2000s, seeing residents who were going to a nursing home for reasons that absolutely didn't require that level of care and that cost of care, not to mention the disruption of their lives that they had to leave their homes to go to an institution. And last, of course, is the most important reason, and that is that everywhere in this country, we have enormous, not only volume of assisted housing, but in many urban areas, you also have density of affordable housing so that you're able to create a very efficient, lean care management protocol across the properties and into the neighborhoods. And we think we bring value to the payer and primary care practice world because we're able to organize networks of housing organizations, just as you have done under PCP, where you're organized as payers and providers. We're able to do that organizing on the housing side and aggregate up the organizations in your region so that you're dealing with one unit. In Vermont, we deal with all 140 sites are one unit. We speak with one voice. Providers don't have to deal with each site individually. This study that Leading Age conducted in 2014 just proved that residents in HUD-assisted housing were spending more on Medicaid, on Medicare, were more likely to have 5 or more chronic conditions, and so obviously a really good target population for chronic care management. This map is a map of all the low-income housing tax credit properties in the country. You can see there are thousands of them. And if you layered over this map and showed HUD projects, RD, mobile home parks designated for seniors or otherwise, you would quickly see that the platform exists to bring population health out to these existing properties. It's a paid-for platform. There's no need to create new settings, new care settings. It's right where the highest need people live. And I would hasten to add that in all those properties, you have staff, you have maintenance techs, you have property managers, resident service coordinators, you have armies of staff that have something valuable to you, which is knowledge of the resident population. You know, we have known some of our residents for 20 or 30 years. We know them sometimes better than their family members. And so our frustration prior to SASH was that we were prohibited from talking to the mental health agency about residents. We knew a lot about them that could be helpful to case managers, but we weren't able to share that. So SASH has created a protocol to share information that's HIPAA compliant, that is consistent with privacy laws. And so now we're able to share the knowledge we have with the provider team. And last, before I turn it over to Stefani, I just want to note that this spring, the Health Affairs held an event in DC where they presented a article written by Carolyn Pearson from the University of Chicago and David Grabowski from Harvard Medical School. They were co-presenters at an event, Health Affairs event in DC, where they presented an article on what they call the forgotten middle. These are seniors that they predict will be both facing affordability issues on the housing side as well as on the healthcare side. They quantified the number of 14.4 million of these middle-income seniors. These are not Medicaid-eligible seniors. These are just slightly above Medicaid into the middle-income population. So just a huge demand coming down the road that we will need systems in place to support them, to make sure they don't spend down to Medicaid. And again, we think SASH is the kind of model that can support this middle income population. And now I'm going to turn it over to Stefani.
Great, thank you, Nancy. And I want to tie this into a lot of what you all are probably very familiar with, is the conversation around social determinants of health and health equity, which affects all of what each of us do in healthcare and in the larger social services world. And when, as part of my work at the University of Vermont Health Network, I was part of the American Hospital Association, the Hospital Community Cooperative, and we're really trying to look at which hospitals and health systems could be early adopters and looking at how we really create these cooperatives that go out into the community and figure out upstream solutions to really, cost and quality outcomes and working together, whether it's the technology and integration solutions or other efforts that are happening. And it's a great initiative. And as I was with several hospital partners from around the country and also social service providers, it's a lot of people looking at small pockets of pilots and also the hospital saying, they're early adopters and they're innovators, but how are we going to pull this all along to the mainstream? It's such a big shift, both from a cost perspective and just a practice perspective, to change the way we've done things. But looking at the social determinants, so this is some data from that group of people, is why I wanted to frame it in that way to you. And I'm sure you're familiar with a lot of this data. And what I want to focus on here is looking at the social determinants, is just these are things that we have an issue with the amount of people who are homeless or chronically homeless. And then once they are housed, we have to keep them housed, which is where something like SASH can come in. But the big things to focus on, too, are looking at the fact that 3.6 million people can't access medical care due to lack of transportation. Yet we keep financing things through our healthcare mechanisms where we require people to get to their medical care. And that's the problem. Part of the large problem is, they have to go there for their services or even care coordination. So we want to look at how do we all work together to streamline these efficiencies. And then, of course, people are facing hunger, people are food insecure, and there's so many decentralized services that we just can't ask our primary care physicians and our care coordinators based out of primary care to figure out all these resources. So there's a lot of ways we can create more efficiencies in the networks that we have. I imagine that many of you have seen this, that really the impact of social determinants of health, that really when it comes to a person's health and well-being and these costs, that healthcare is only 20% of where we can help a person's overall health and health equity. It's all about their physical environment, the social determinants, and really their behavioral factors. And health behaviors happen at home. That's what we know, but we need home to be tied in to healthcare. We all need to figure out how to work together. And there's been a lot of years of pilots and demonstrations, and people are still scratching their head, but there really are solutions that are evidence-based that work. It's how do we integrate them together, and that's where we really feel that SASH has these proven outcomes, and housing as an integrated care system can really work. The biggest thing for this slide that I want to focus on, in this image I've seen this kind of chart portrayed several different ways in many different publications, is across the bottom where it looks at health outcomes. And it's just drawing that conclusion that when people are facing one or all of these different social determinant upstream factors, if they're not addressed, it is affecting every health outcome that is important to all of us in the health system, you know, as payers, as all of it, is that it affects life expectancy, expenditure status, you know, all of it. And yet, as healthcare systems, we're just not very well equipped to focus on these social determinants. And we've got to work with the people who are well equipped and create a system. And that's what's really a challenge for us right now. I love this slide that came out of an article about how do we look at redrawing medicine, how do we focus, you know, healthcare and medicine differently. And this is now a few years old, but it still, to me, has a huge impact in that we want people, you know, we always say to operate at the top of their license, to be able to do the best they can. What does that really mean? And we look at CPC Plus, or now Primary Care Plus, and the dollars to me are still going straight into the practices, but we need clinicians to do what they are trained and excellent at doing. And what this slide says to me, if the social determinants are not working, if people don't have food, transportation, their housing is unsafe, whatever it is, then our clinicians can't do the work they are excellent at and that they're trained to do, because they just impede that work. And people, honestly, as humans, can't focus on their medical conditions and their chronic conditions until they're centered around those factors in their life that are really affecting them day to day. And I think that's really important to realize, that we are all in this together because things are so tied together in this ecosystem. This also really speaks to me in the fact that even Florence Nightingale, this is something she said a long time ago, and it's still very true, is just the connection between the health and the dwelling of the population is the most important one that exists. And, you know, going back to the model of, we're not going to go back to the physicians that came to visit you in your home, but it really is the key factor around SASH is that longitudinal relationship that the care coordinators and the wellness nurses have with the people who live in the buildings is irreplaceable, in the fact that it's that combined with the longitudinal relationship of a primary care physician and others. The home health nurses, when people are in acute need, can come in and out of people's lives. Case managers sometimes come in and out, sometimes they're longer term. Emergency rooms, unfortunately, are starting to have very long-term relationships with these highly complex patients. And that's not what we want our emergency rooms to be, but it is what's happening, whether people are the chronically homeless, people with substance use disorders, mental health disorders. We want to put those longitudinal relationships where they belong, which is where people live, and those care coordinators can focus on getting them the services and communicate with the primary care providers who also have the key long-term relationships, so that people are connecting with what they need to. I've seen a lot of projects come out on how to make better referral directories for primary care offices to understand which social services to refer to. And I think while those are great efforts, it's also still asking a lot of our primary care offices to start to understand the entire social services network in a way that is just putting, to me, an extra burden on them, when people are really going to access those services probably from home, or they're going to change those behaviors at home. and having those care coordinators where people are and where they're going to change the behaviors has a much larger impact. I'm going to turn it over to Nancy again to talk to you a little bit about how SASH really works. It's a lot to get through in a short period of time and really understand the full comprehensive look at what it is.
Thanks, Stephanie. So the bottom line is that SASH is about tying innovations that already exist together. It is not creating a new program. Sometimes people ask us, do we choose SASH versus PACE, or, is it an alternative? It's not an alternative. It's taking what is the many, many, many skills and services that healthcare providers and home and community-based services offer and knitting them together into a system that not only integrates, but then creates this integrated platform that then you can build upon and offer even more services that are effective. So the way we approached the integration was to literally create memorandums of understanding with all the players in our state, beginning, of course, with medical homes across Vermont. We have an MOU with every hospital in the state, as well as Dartmouth across into New Hampshire. We have 22 housing nonprofits in our state. I'm sure you have an equal number in your regions. So we, again, organize them together so that healthcare providers do not have to deal with each individual organization separately, but could deal with us as an aggregated group. All our area agencies on aging are part of SASH and key to it. Our mental health agencies, which I would say is the largest need we have among SASH participants, is very complex mental health issues, behavioral health issues, addiction, and being able to work with our mental health agencies to address those issues. And then we have a network of home health agencies in Vermont that, of course, are our partners in coming in to apartments right after discharge and making sure that the residents get the skilled care that they need. So the core SASH team, it's an embedded team of a full-time care coordinator and a quarter-time wellness nurse, serving about 70 to 100 participants in SASH. And those panels, as I mentioned earlier, can be, all of them could live in assisted housing. And when I say assisted, I don't mean assisted living, I mean assisted with federal or state subsidies to keep the rent affordable. Some of the panels are all in the community, 100 people scattered around a city or town that SASH supports as a team. And some of them are mixed with a congregate or a couple congregate properties, and then some individuals that have enrolled, often because of a primary care physician referral, where they really see that this kind of intensive support could help their patient manage their chronic conditions. So how it works, as you can see from the diagram, the patient is in the middle of everything. They're in the driver's seat. We know that motivation is required for any of us to change our deeply embedded bad behaviors. And so we need to understand the motivation that would create that change. And so we begin SASH, the first step is conducting a person-centered interview with each person who, of course, enrolls voluntarily. And we listen to their life story using different tools, whether it's looking sort of the linear history of their life or looking at relationship mapping. I'll give you an example where we really found the root motivation for a woman in her mid-80s who was in a wheelchair. And during the course of the interview conversation, the resident explained that she was forced to give up her son for adoption decades ago, and that ever since then, she really wasn't motivated around much. So the SASH coordinator said, well, then as we build your healthy living plan, your individual healthy living plan, what if our first goal was to find your son? So they did, and they found that he had a child, and that they live in Florida. And, well, she found her motivation. So she has left public housing in her 80s. That is unheard of, that people leave public housing at that age. She's really addressing her chronic conditions, just a huge change. So that's at the heart of SASH, is that until we really know what motivates people to change, people may change briefly, but sticking to healthy behaviors is a lifelong challenge and really requires that you get deep into what motivates that change. You can read, we've got a lot of components. We use a uniform screening tool with validated screens and assessment. We create an individual plan for each individual. Rather, we don't create it, we create it with the individual. And then we look at the whole 100 people on a panel and come up with a plan for that group. You know, what evidence-based program is needed to address the needs that we're seeing that are significant within the group, whether it's pain of arthritis or other conditions that we can bring in evidence-based programming. We have a shared data platform focused on prevention, always using students from the many universities around Vermont, colleges and universities, doing the rotations at SASH sites, and providing a huge service to our residents around, brown bag medication looks. And as I mentioned earlier, telehealth is tricky, but something that we are moving forward on, because we need to have that electronic capacity to conduct physician visits when a person can't or shouldn't be leaving the building in the middle of winter, or when they have difficulty traveling. When we started to design SASH, we read a lot of literature and came across an article that emphasized the point that although there have been models that have focused on transitions of care, on self-management, and on care coordination, at the time, and this was in the, I'd say 2005, that no model had attempted to merge all three. And so that we felt that would be important to do. So we are very focused on transitions of care, very focused on getting our residents out of the nursing home as quickly as clinically possible. We don't want to run out the Medicare clock at nursing homes. We want to get them home as soon as it's safe to do so. Lots of health coaching on chronic conditions, and as Stefani will tell you later, great results on improving chronic conditions. And then in terms of care coordination, again, really just understanding what a person needs and being in daily communication with them about, are they going to the doctor's office today? Do they need a ride? Do they know why they're going? Do they have their profile from our database printed out so they can hand it to the physician, so the physician or the hospital knows that the person, yes, does have advanced directives signed, or yes, has a DNR or doesn't. When we started this, we knew we had to go statewide. And that's for not only mission reasons, but also operational reasons and political reasons. We knew that operationally, we were going to need to have a very lean, constant, continuous training and technical support capacity, so that nurses often, in remote sites in Vermont, had a constant means of support and source of advice throughout the program. And that, of course, the goal, as Stefani mentioned, is continuity. That we have had some nurses that have been at the same SASH panel for now 6 or 7 years. And so they know their population better than anyone else, and that's hugely valuable. And as you can see in the map, we did divide the state up into 6 regions. We did that because we know that local partnerships are going to be stronger than statewide partnerships. We wanted to be sure that the hospital in central Vermont that knows the housers in that region are talking with each other, and that it isn't Cathedral Square, which is in the Chittenden County, more urban part of Vermont, that we're not there trying to create the partnership relationships that we can't and shouldn't be doing. And then it allows for real great local variation so that SASH is tailored, for example, down in Windham County, which is in the southeastern corner of the state, bordering New Hampshire and Massachusetts. They had a very limited EMT ambulance service that serviced almost all of the SASH properties. And so it was important to them to actually team up with them, have them come to the monthly team meetings, because they knew so many of the highest need participants on the panel. So before I turn it over to Stefani, I just wanted to talk to you a little bit about the flow of dollars. So basically, the panel of 100 people is funded at $70,000 per year to fund the full-time SASH coordinator and the quarter-time wellness nurse. When we were in the MAPCP demo through CMS, those dollars funneled through a local community hospital and then out to the housers. Now that we are baked into the all-payer model in Vermont that is administered through our ACO, our Accountable Care Organization, those dollars flow essentially through the ACO out to the housing groups. In addition, because of our key relationship with the state of Vermont and the Blueprint for Health, we have an agreement with the state so that Cathedral Square, as the statewide administrator, is responsible for HIPAA compliance of all the housers and the training and all the statewide functions that need to happen in a very efficient way. And then, as you can see down in the third box, we have the DROs that I mentioned, the 6 regional groups that operate the panels, not only for their own organizations, but they're supporting the other housing organizations in their region. Again, so that the healthcare provider network isn't dealing with individual organizations, but rather dealing with one whole group. And then, as you can see on the bottom, our key partners, and I would add the Department of Health has been a huge partner with us back in the day when states were receiving community improvement grants, I think they were called, through the CDC, which no longer exist. We were funded to begin the hypertension protocols, and now we're working on diabetes protocols that are similar. So Department of Health has been a incredibly valuable partner, and the way they kind of look at SASH is there's a statewide platform that's built. So if we have an initiative, Zero Suicide, for example, a new initiative, we can just run that initiative out across the SASH platform. We don't have to build a whole new system to implement new initiatives. So with that, I'm going to turn it back over to Stefani to talk about outcomes.
Great, thank you so much. And so as we started with the Forbes article, with that initial question about savings, there's more of this, and I think that what is really important is that we keep looking at how do we do those pilots and demonstrations, but it's been proven, that article that Nancy mentioned, what if you combine transitions of care, self-management, and care coordination, what happens? Well, the answer is wonderful things happen, and Nancy's going to talk later about where SASH is expanding to and how we want to expand further to really help. But here's some of the things that have been found as RTI, Leading Age, and ASPE have evaluated SASH. So just one of the I would say smaller pieces, but it's all actually huge, better medication management. And this is a quote from the study, is that SASH staff help identify participants' potential medication problems early and prevent medication mismanagement. And this is actually huge because what this does is it prevents ER visits, falls, all kinds of high-cost care that is much harder to quantify, but because these nurses, as part of the annual assessment, are going into each person's home or apartment or mobile home and saying, let's take a look at your medications, pull them down off the counter, let's sit and look at them, and they're tracking them and comparing them also to any medication list they might have from the physician, and then making sure the person understands, and actually then, with the person's permission, calling the primary care physician or a triage nurse and saying, there's a little bit of confusion here, we want to make sure this is correct, and they're clearing that up. And when someone brings down a bottle and says, I don't know, it's not feeling quite right, realizing they have 2 bottles mixed up and they're taking a pain pill instead of a nausea pill the wrong amount of times a day, and that's why they've been dizzy, those are huge factors of having that person in the home. So that's one of the things they found. On this slide, this is about the first time I started telling the statewide nurses, this was in our very early years, I started telling them some of the cost savings that were coming out of it, saying we're saving Medicare this much money. And the nurses said, that's not that important to us. We feel like our people are healthier. What can you tell us about the people we work with every day? What data do you have on this? And I realize you have to know your audience pretty well, but we are excited to now have this data on it. And as Nancy has mentioned, our partnership with the CDC and our Department of Health, we've done some really great initiatives. So compared to US statistics, SASH participants now have, 76% of them now have controlled hypertension as compared to 48% of the US population. And when we started this initiative, it did not look like that at all. We have the same number across the state of adults with with hypertension and B, with uncontrolled hypertension is what we had as similar to the U.S. when we started. And based on the CDC developed initiative, protocols we put into place, strategies, blood pressure clinics, we've brought that down, and it's just, or brought the number up really to controlled. It has been amazing. Our vaccination rates have gone up steadily over time. Both pneumococcal and shingles are going up, and then we've just made it a best practice that flu vaccine is always happening there, making sure those are scheduled. Falls risk, people want us to say that we've decreased the amount of falls in older adults by a significant rate. And what we've found over years of studying this is that because we always have new people entering the program, and also our people are aging, is that we are never going to be able to, with this population, to get the reported falls down to 5%. It just can't happen. So our goal is to keep our falls rate below the World Health Organization or on par with it, so it's at least not increasing, and we feel like that's a win, just knowing what's going on with this population. So we track both falls risk, and we track actual falls, whether or not there was an event afterwards. Did they, have injury? Did they go to the ER? Did they have an inpatient? We track all of that. What's great about the risk screenings that we do is we can identify, we always use data to plan out both programs and education. So people who we know are at risk of falling, we can do some targeted initiatives with those folks. And we also know we track adverse risk medications, all of those things. So we do targeted outreach, so hopefully preventing adverse events. I talked about advanced directives. We have really seen an increase in that, and that is a lot about some one-on-one and group education, helping people understand what their options are, the difference between COLS, DNR, advanced directives, and really end-of-life planning. A lot of people's personal goal is to live in their apartment until they die, and to die well, and we'd love to help them with that. So we do a lot around that. So here's more detail on the hypertension collaboration and just seeing how much we can help with reducing their systolic blood pressure, the 15 mmHg. And this is really, and of these, more than 50% moved into a lower risk category between high, medium, and low risk for their hypertension. So this has been really great, and we're now looking at how we can move this initiative. It's something that can be easily replicated with training tools out into other communities when we talk about where we're expanding and the national demonstration that's happening. So this is really nice, and as Nancy said, we're now working on a diabetes program as well. So if you think about it, how much do payers spend on these chronic conditions, these really high-cost ones that are very common, diabetes, hypertension, and behavioral health is really hard to measure payment on. You all may know this better than me, but we know it's a huge factor around chronic conditions. But that spending and incidence rates among residents have a big impact. But what we do know from SASH overbeing studies is that the independent evaluation found statistically significant Medicare savings, first off, of $1,227 per person per year, which is a lot, and that's after the costs were taken out of it. And when this was done, we had 5,000 SASH participants in the state. So it's impacting both quality and cost for them. And we're really excited about those statistically significant savings. And then this just came out recently, is that Medicaid spending is also reduced by $400 per participant per year. And, you know, there's always some nuances to the details in it, and these are very, very specific studies. So we are excited and really looking at how to expand into a Medicaid population. We have most of our folks, the highest percentage are in the dual population, which is, as you know, the highest spending population. Oh, I'm going to let Nancy talk about expansion and what we're doing in other areas.
Great. Thanks, Stephanie. So we're going to wrap this up and just talk a little bit about, so after SASH was beginning to show results, HUD and HHS got together and wanted to fund SASH in other states. So they received a $15 million appropriation. They call it IWISH, which stands for Integrated Wellness and Supportive Housing. And so you can see 7 states, 40 sites. It will end, the test period will end in next September 2020, and it's under evaluation currently by APT Associates. So we'll see what kind of reduced utilization results we see. I mean, this map overlays those HUD sites built on the SASH model, as well as the places that we have replicated SASH. So we have replicated it in Rhode Island, in Minnesota, and are currently working in New York, Maryland, Virginia, Florida, Texas, California, Oregon, and Washington State to replicate it as well. And really do want to take the value of this work nationally. So we would wrap up by saying, asking you, what are your thoughts about what it would take to, to bake SASH into other work, your work or other work around integrated systems of care and population health. We know that what is required is first commitment to systems change, which CPC Plus has, obviously reimbursement for care that's value-based and outside of the traditional payment mechanisms, which of course CPC Plus does. Care, primary care, and hospital support, again, you've done that, you've got that. Housers can do the work of aggregating seniors within specific payer service areas or practice service areas. We can also strengthen housing and care management networks. That's our value. And I think, together we can obtain more Medicaid and Medicare support for these blended models, as well as our real focus today is on looking at multi-payer models for permanent funding of SASH as part of a larger system. Again, bringing together public and private payers to fund what we know is bringing down costs, increasing access, improving quality, and doing that within a medical home framework, just as you are doing. So thank you so much for listening, and Stefani and I are here to answer any questions you have.
Great. Thank you so much, both of you. It was a great presentation, and it's really very exciting to see the potential expansion of a program that we're really so proud of in Vermont. I'd like to turn it over to anyone else in our group. There's about 20 people on the line, and sort of hoping that we'll have some questions. If not, I'd be glad to ask a few. A lot of you are self-muted, so make sure that you're taking yourself off mute. So I'll just toss out a question first. So just thinking about the future, and really, this is really a question for either of you. When you think about the next steps and how to really have substantial, tangible movement towards moving this broadly, what do you feel like are the key elements at this point?
Thanks, Lisa. I think the key elements, for example, as we work in Virginia, is to begin to organize the housing organizations. And that's a process of educating housers around healthcare language. Stefani and I teach a course, national course, 2-day course on health and housing, where we really do try to educate housing and community development corporations about what is an ACO, what is a value-based payment, what's the difference between Medicare and Medicaid. It's really about getting our side organized so that we are easier to work with for payers and providers. And I would look to Stefani to see if you'd want to add to next steps.
Well, see, I would say the flip side of that is when we teach that course, and actually I bring up the concept of cultural competency, not in its traditional sense, which is, when we work with patients, is that there's a cultural competency issue but we need to break through between healthcare and housing, is we need to speak different languages. And so in the same way that we're teaching the housers how to understand all of our healthcare terms about ACOs and population health, that I do think many social service organizations approach, whether it's payers or hospitals or people with pilot ideas or demonstrations, social determinant, how do we help you solve this upstream problem? And I think that we're going to speak a lot of languages that don't make sense to healthcare or new terminology, even the term of care coordinator. So we consider, the SASH coordinators, care coordinators, but then that can be used a bunch of different ways. And so to me, a next step is really helping healthcare and payers and people understand that there are already systems that are evidence-based with outcomes out there that work, but we need to work together to kind of fund and implement these in a systematic way in states and nationally. And I wanted to reference that there was an Urban Institute report that came out this month that talks about how hospitals can help with housing and with costs. And it's not, I think hospitals often feel like they need to build housing, and in some places, yes. Do the hospitals need to build it? No, I think that's a scary concept, but we don't have enough affordable housing. But there are other aspects to this, and it's something like the SASH model that by providing nurses, providing funding to help establish these networks of care, then that's a real opportunity. Nancy, you wanted to add something?
Yeah, I just wanted to add that our focus right now as an organization, as the National Low Home Network, is to take a recent paper that was published by Harvard Medical School, our organization, and Leading Age, that really focused in on what are the potential permanent funding mechanisms for the housing embedded care management. And we would really like to identify foundations that want to work with us to test those funding models real time, in real places, not just hypothetically how they would work, but actually how they would work in collaboration with existing networks of payers and providers, whether it's working with an ACO or with the PCP Plus region or with other existing networks of providers so that we really can test out what works on the funding side, because there is so much interest in among housing organizations to make sure their residents can age in place safely and not incur nursing home costs. But without a permanent mechanism, other than that HUD demo I mentioned, where funding was offered, and there were 40 slots available for that HUD demo, and 757 housing organizations applied for 40 slots. So when there's resources and you see the interest is there.
Thank you. So we have a number of regional payers on the phone, and obviously this is a web logged on, and these are organizations that have stepped up to the plate as being part of the Comprehensive Primary Care Plus or other payment reform and primary care transformation programs. Do you have suggestions for them in terms of, obviously it seems like there would be some opportunity to potentially connect with regional housing organizations in their geographic areas, but is there some sort of central way for people to get involved and learn more if they want to?
Yes. So I would invite anyone to contact us. Depending on the region, there are different existing networks. One of the things that we've been kind of excited about doing is GIS mapping the housing that's in particular regions, states, cities. So because I would think what's most important for regional payers is to understand, there are actually hundreds of potential platform sites that already exist in their service area. I would also say if there are leading age chapters in most states in the country, and we're happy to connect you with them. That is a membership organization of nonprofit aging services providers representing the whole continuum from housing to assisted living, nursing homes, home health. But if any of you were interested in trying to bring the housing world to further your goals around improved quality and access and reduced costs, we would love to work with you.
Great. Any questions from the group? Okay. Well, thanks so much, both of you. Really appreciate your taking the time and the resources to provide this information to us. This has been recorded, so if you have colleagues who would like to take a listen to the webinar, they're welcome to do so. We'll be posting this to our website, the Milbank Memorial Fund Multi-State Collaborative page, and we'll also have a link to the slides that Nancy and Stephanie used, as well as to some of the other reports like the Urban Institute report from earlier this year. Thanks everybody. Have a great holiday weekend, and we look forward to being on the next webinar together. Bye.
Thank you, Lisa.